Good evening, everyone, and thank you so much for joining us for our second conversation in the Amplified series. My name is Peron Yusufzadeh. My pronouns are she, her, hers, and I am Jiva Theater Center's Associate Artistic Director and Director of Engagement. And I Zoom to you tonight on the ancestral land of the Onondaga, known in English as the Seneca people, and give thanks to their elders, past and present, who have stewarded this land for generations. I'm going to turn it over very soon to our incredible panelists and moderator. Before I do want to go ahead and introduce them. Also, just as a bit of housekeeping, as the webinar is taking place, please feel free to use the Q&A function or the chat function to put any questions that you have for our panelists there. We will have about 15 minutes at the end for questions and answers. And so as things come up for you as they are in discussion with one another for the first 45 minutes, please feel free to use the chat and we'll try to make sure that as many of your questions are answered as possible. So without further ado, I'm going to introduce our incredible group of panelists and invite them to all turn their cameras on as I introduce them. This is Margie Hodges Shaw, an associate professor in the Division of Medical Humanities and Bioethics at the University of Rochester School of Medicine and Dentistry. She teaches on the intersections of law and healthcare, medical judgment and decision-making, and bioethics, and serves as a member of the Clinical Ethics Consultation Team. She presents nationally and internationally about how to teach the knowledge and skills necessary to navigate difficult conversations around morally complicated topics, including content relevant to inclusion and diversity. Dr. Shaw received her undergraduate degree in political science from North Carolina State University, her JD from Cornell University Law School, her MA in philosophy from the University of Rochester, and her PhD in education from the University of Rochester. She completed a fellowship in clinical ethics at the University of Rochester School of Medicine and Dentistry. Welcome, Margie. Thanks so much for being with us. Bryan Vincent Redmond is a third-year MD PhD student at University of Rochester School of Medicine and Dentistry. He is a native of Memphis, Tennessee, and graduate of Xavier University of Louisiana in New Orleans, Louisiana. Currently, in the PhD phase of his dual doctorate program, he is a student in the Department of Neuroscience and researches psychophysical therapies to optimize visual recovery in stroke patients. Bryan is also a member of White Coats for Black Lives. Thank you so much, Bryan, and welcome. And last but certainly not least, Shani Wilson is an internal medicine board-certified physician assistant with areas of expertise in LGBTQ+ health, sexual health, minority health disparities, with emphasis on mental health, medication-assisted therapy for opiate addiction, trauma-informed care, and vaccine-preventable diseases. Community activism and engagement has been especially important to Shani. She is passionate about also giving a voice to the underserved people of Rochester. She also works closely with local LGBTQ+ organizations such as Rochester Black Pride, where she currently serves as one of the co-organizers. She also is currently chairing the Rochester Police Accountability Board, which is one of the first in the country. Welcome, Shani, and thank you all so much for being here. I'm going to go backstage now and have our brilliant panelists here take it away. Just once again, audience, thank you so much for joining us. Use that Q&A function and the chat function and enjoy the Amplified series.
Okay, hi everyone. Thank you so much for joining us tonight. So really excited about this panel and really excited to hear some of the conversation that's going to be brewing and what we're going to actually talk about when we talk about the bleeding class and about what this kind of brings up for us in this discussion for the next couple of minutes. So one of the things I wanted to start with was actually just talking about what this actually, like just getting a general overview of what the panelists thought about the bleeding class in itself, and just giving their thoughts about like what kind of stuck out to them as far as like, you know, as clinicians, as people in medicine, like what were their initial thoughts around the bleeding class in general. Margie, you can go ahead and start.
So I'll have to say, first of all, I'm delighted to be here. Shani, thank you for moderating and bringing us together. And Bryan, it's nice to see you. It's been a little while. So this is when I feel luckiest to have the job that I have, is that I get to listen to the Bleeding Heart and call it work. It was a pleasure. And so for those of you who are participating who haven't had a chance to listen to it, you're in for a wonderful performance. There is so much in this performance that is relevant to today and relevant to our past. And so that was quite striking. One of the things that struck me about it that was, I think we don't want to lose sight of, is that the individuals who were depicted, the wholeness of the humans that were there, they were just delightful people. And that was something that was nice to have come out as part of the performance.
Yeah, I've got to second that. First of all, Dr. Shaw, it is a pleasure to see you. Dr. Shaw taught me medical ethics, so it's good to see you. Again, it has been a while. I struggled initially with the idea of an audio production. I worried that it'd be difficult to connect with the characters and to sort of position myself, in their shoes. But early on, with sort of the characters present their personalities very early, and that humanistic characteristic is revealed rather quickly. And the characters are their true selves the entire time. And I think that there was something that really helped me connect with the idea of a class bleeding. Is the initial part of empathy requires us seeing folks as human beings. And I think the bleeding class does that perfectly and throughout. And they continue to remind us of the humanity relevant in the characters. And I think that is what strings together the message perfectly.
Okay, that's awesome. So I guess wouldn't be a conversation. I know I'm the moderator, but got to say something. So I think, I always in these areas, my family's from New York City. And, the main character was a Dominican woman, and very much reminds me of home, and it reminds me of, people that I've known my whole life. And so, it was easy for me to kind of visualize the characters. It was easy for me to think about a patient that I've had that was probably one of the main character. I think that, they did a very good job of, I know that I wonder, and I would ask the person that wrote the play for the bleeding class, like, did you take this from Henrietta Lacks? Because it definitely, I could see the parallels there. And especially with just like the thing that I found really difficult, especially as a Black woman, as a woman of color, is just the I would say the lack of medical knowledge that we all have to deal with when we're dealing with these types of subjects. That, it's like and we've all sat in the room where it's like the yes, okay, and whatever you say, doctor, and, I'm going to let you take the helm because you know what you're talking about, and so that was really difficult for me to see. And those are just my initial thoughts. But I guess the second question is that, as a, so you talked to me, both of you talked to me about what the bleeding class, like as a person in your personhood, about what that meant. But as clinicians, or as people that deal with medical ethics, and also a medical school / medical student, what are the first things that you take away from the bleeding class, and some things that kind of jump out to you as overarching themes? Bryan, if you could start, please.
Yeah, when I took a biochemistry course, what my professor used to always say is that water is the solvent of life. And when we think about humanity and we think about the human being, blood is kind of our solvent. And the title of the production was The Bleeding Class. And they kind of alludes to the idea of extracting the solvent from someone and extracting the solvent from a class of people and utilizing it for gain. And from that initial interaction between sugar and the physician, you kind of expect that there's going to be some manipulation, between these two individuals. Someone was going to be a loser and someone was going to be a winner. And of course, we see this play out, as they create the treatment and the vaccination for the HXNX virus. And I guess I think about that, in this relationship to medicine, and you've alluded to Henrietta Lacks, but I think about too in society, who are we bleeding? Who are the losers and who are the winners? Those are some of my thoughts.
Margie.
Yeah, I'll echo. I'll first acknowledge that I called it the bleeding heart instead of the bleeding class. And I did that, I think, because it's such a heartfelt, it really pulls at the heart, and it pulls at the heart because of the history of it. But it is really, really important to acknowledge that it's the bleeding class for a reason, right? It's not just any heart, it's hearts of a particular kind that belong in particular kinds of bodies. And so this relationship between, and there's so many points where we can talk about problems with the relationship between people of power and not in power, depicted in the performance. And Bryan, you referenced the main character's name, Sugar. But it took 2/3 of the performance for the doctor to be able to call her by her name, even though she begged him to, right? She asked him to show her that respect, and he still couldn't do it. And there's so many places that are built throughout where there are failings of one person to show respect to another. And it's all in one direction. The failings are all in one direction. And that's, and that isn't just from Henrietta Lacks, it's from our history. It's from all of our history.
Yeah, that's a great point. I think that actually stuck out to me as well, right? In school and in medicine, we're taught that, you don't I was having a discussion about this with a family member today about, I never can understand what they're saying. They always talk over me. And, I can never, they always will have, they'll explain to me in big words what they're saying, but I don't really know what that means. And so, I just need them to slow down and talk to me like I'm a human being, but really remember in the history of, exploitation in these areas, it's like there was always a lack of humanity, right? There was this always just we're going to treat you like a number or or a thing, which is really what Sugar was treated like, right? It was like you were an oddity and an abnormality, but we'll keep you in this place and keep you kind of in a very small area with not a lot of people around you, except for, interestingly enough, another person of color that is supposed to be working to take what we need from you. So we're going to put somebody that looks like you in front of you so that you can trust them, so we can get what we need from you, which also kind of parallels to some things throughout history, right? Yeah. So I think I wanted to just ask about, in that way, one of the things that since I talked about the Tuskegee Effect, and I was wondering if Margie, you could just talk to us about what that is and what that means in regards to the play.
Sure, and you've already referenced it, right? So in Tuskegee, the scientists weren't all just white, and they also had an African-American nurse serve as a conduit to get participation. And you also referenced the use of discussion and language and talk down to, or not, this failure to communicate with the person in front of you in such a way that helps the person understand what they need to understand. And it's by using the right language, but language that's intended to get a shared decision-making process. And none of that existed in our past. And so I'm hopeful that everybody who's participating knows about the Tuskegee study. It's one of those horrible incidents in our American past, like so many other, but this was one that involved research of Black men in Alabama, and it was a lifetime study of the effects of syphilis on the Black body. And even when doctors had a cure, a treatment for syphilis, these participants were denied access to that because this was intended to be an autopsy study. And so this was a study where medical professionals, just like in the performance, the bleeding class, where medical professionals used the bodies of others for their own gain and their own purposes. And that purposes might have been knowledge, and they might have justified it in their own minds for certain ways. But the fact that they used other people's bodies was is undeniable.
And that's a very interesting phenomena. The direct, overt disenfranchisement of a patient for gain. And I think sometimes in medicine and in clinical settings, there are opportunities to educate a patient, to provide healthcare literacy, to help them understand their condition. And within the bleeding class, there were multiple moments in which Sugar demonstrated that she could understand anything you could tell her. She could. She understood disease. She understood her immunity. She even described that her entire life she'd never been sick. And she even understood that, the billionaire who she interacted with probably, communicated a disease to her. Yet everyone in power, even in research and in the physician, they withheld information from her. That overt intention to keep someone who has a capacity to learn ignorant.
I think the thing too is that, at one point they called her the Rosetta Stone of medicine, right? And that, this was the holy grail of medicine, that she was just such a medical oddity / discovery that, and it was really, remember, it was the Black doctor. We imply that he's Black, I think, right? We don't know. But, the doctor of color, which was implied during the play that, but have you thought about this? Right. And then all of a sudden it became, the intentions got muddled and it became a gray area, which is always the gray area is a scary place, right? Where you're trying to figure out, especially in research, and then research becomes experimentation, or, even in medicine, when we see that there are I'll just say it, like, there's questions that people have that you just as a clinician don't have time to answer because you have to go to your next patient, right? So, or that there are definitely questions that you have to get to at the next visit, and then that never happens for some reason because you just lose track of the patient or something else happens. So, one of the things I wanted to ask is, what do you think explain what you like, what does the word weaponization of medicine, what does that phrase mean to both of you? And anyone can jump in.
After you, Bryan.
Yeah, it's a heavy word, and I'm reflecting over it from a clinical standpoint, and even in medical education, medicine can be weaponized, but definitely in a clinical standpoint and in research and science, like IRBs and review boards who review experimental protocol when they don't make mention of specific public health and epidemiology standards that should be followed for individuals or specific groups. When folks are a part of clinical trials and sign consent forms without proper understanding, we see medicine weaponized in so many ways. I would say even, the lack of effective resources in a space where they're needed, the lack of effective clinical resources in spaces where they're needed is medicine, being weaponized in some way, shape, or form. But I think it boils down to individuals being disenfranchised in clinical spaces. Medicine can be weaponized in so many ways. Research has been done in emergency departments where patients report a complaint of headache, and you see that patients of color oftentimes aren't prescribed narcotics, aren't given neurology consults, even with the same, reported pain as their white counterparts who receive, stronger prescription drugs and neurology consults, and their concerns are taken. Their concerns are viewed as more important. I see this in my learning where, we as medical students are often given more independence and freedom to patients of color. you know, we get to poke and prod them, you know, when they're having complicated deliveries, and this contributes to, you know, disproportionate maternal mortality rates. You know, it's a difficult terminology, and I think it plays out in scientific and in clinical and in socioeconomic spaces.
So I think of it in two ways. One is the way that Bryan just talked about, which is that where it is used as a sword in a sense, right? That it's that medicine is what we have to offer, and the reasons behind that that Bryan talked about maybe implicit or explicit racism, which exists, and that's part of it. I think there's another reason too that is equally important, and that's it's used when we're afraid of what we don't know. And so when there's uncertainty and we don't want to show that uncertainty, and we hide behind what we do know, which is often scientific knowledge, and not doing what we really ought to do, which is show our own vulnerabilities and show our own humanity in a respect of the other person's humanity, and to engage in an authentic conversation rather than hiding behind medicine. So I think it's the combination of those things, and that's a lot when you combine them. That is a lot of what happens in medicine.
Can you, and I know that you've been, do you think you can give us an example of that, of where there's an example of, I know this is kind of I think I just would like to hear an example, if you have one, of a time where there was a study or some sort of incident that you know of within the ethics world, bioethics world, where there was not that humanity given, or that there was not that that clear line of we just don't know, but instead it was, we're going to take the medical high road.
So, well, you already raised Tuskegee as a perfect example of that, right? I mean, so when the participants were recruited, right, there was an informed, what they claimed to be an informed consent process here. And that process included conversations about, purportedly, about what was going to be provided, what treatments were going to be provided, and for what. And this is the title of the books about Tuskegee. It was called Bad Blood. Well, that's not useful, right? That's not helpful. It doesn't give an understanding. And so there's a hiding behind something, and that we're going to use our expertise and our knowledge, and we're not going to take the time to uncover what this means to you. And I think that relates to Bryan's earlier observation, or Shani, it might have been yours, that there's time limited, right? I mean, clinicians are also working in suboptimal conditions, usually, not even what they're doing now, which is unbelievable, right? It's just incredible in the pressures that they have to try to come up with the language that works for every single individual person. And so they don't always do that. And so when they hide behind maybe medical jargon or sloppy language, so that they can move to the next event that they have to move to. And it might not be consciously racist or intentional, but it's malignant nonetheless.
Mm-hmm. So I guess what I'll do is I'll give an example of my clinic life. So one of the things I think that we can name a bunch of scenarios, but when I was thinking of like not giving patients kind of taking the medical high road instead of like actually having to sit down and explain to someone, on a daily basis. I'm sure that folks that are listening to this can also talk about something that happened in their life where they were experiencing or had a loved one that experienced the same thing when they visited a doctor's office. But talking about a procedure that a patient has to go through, right? And we can only give our best guess about, like talk about back surgery, right? That's a common lumbar, like a back procedure. We'll just say procedure. It could be like a neck procedure. It could be like a lumbar spine procedure. But, we know that it's always, in a lot of ways, it can really define their lives and make it a lot better, or it can define their lives and it can make them the same, or it can make them worse. Right. And I think, one of the things that specifically like that I found a lot of that, like a lot of folks didn't necessarily understand the implications of what back surgery meant. And, you had to spend a lot of extra time with them, trying to help them sort through what was the best thing for them. That might not be 20 minutes, right? That might be 3 visits or 90 days while they figure that out. But, I think too, it's like, we always have to be mindful of the fact that it takes, like, we only have a certain amount of minutes with our patients, and like with a person listening, with a family member should hear this as well, that you may not get your answers the first day, but you can always call and come back the next day, or just there's always room for more conversation. And I would much rather have like for instance, if you have an issue in the hospital, my grandmother, she was hospitalized in the hospital. We had some issue with her medication, and we waited until that doctor came back so that he could explain exactly what was happening to her. And again, he used big words, and I was like, what does this mean? What does that mean? What if I don't understand what cardioversion is, then I need you to make me understand as a layperson. Because, yep, I get it. You're tired. I'm tired too. But we have to make sure that we understand each other. One of the things too is, I think when we use that language, you have to understand that it isolates people, right? It isolates them inside of their illness and makes them feel powerless. And, I think too, it's like, when we have a specific demographic of people like Black and Brown people that have been, they have been told that something's going to happen to them, and we are using their body for some reason, or that their bodies have been used for some reason, and not giving an explanation, consent, any of that stuff, right? That it takes away their humanity, and it also takes away their ability to make a choice, and just isolates them within the choice that's been made for them already, right? So coming back to the play though, we talk about like lack of choice with Sugar, right? Like she was threatened with jail time, that at the end of the play, which I thought was really good, was, that they used her body to weaponize against other Black and Brown bodies, right? Because they said that, or other bodies that had been not, that did not have that were not economically advantaged, right? So I just wanted to hear your thoughts on that. Like, what did you think about that? Because I thought that was really impactful for me. Anybody can go.
Yeah, that was big. And I don't know what comes to mind first. Maybe sort of how disproportionate medical care and institutionalized racism exist. And we're seeing it manifest even more during the pandemic. Before the pandemic, Black Americans, were already, had strained relationships with their physicians. They were undervaccinated, eating unhealthy, managing chronic conditions poorly. And ultimately this burden was facilitated in part by a lack of trust in the medical system. So, the Black American was saying, I'm not seeking care until I absolutely need it. And oftentimes it's too late. We also know that Black Americans, are at a lower socioeconomic status. They live in food deserts, in places where medical amenities like these testing centers, for coronavirus weren't widely available. Black Americans are also living in multi-generational households with less square footage, so it was harder for them to social distance. So Black Americans had, lower socioeconomic status, no trust in the system, pre-existing conditions like diabetes, heart disease, hypertension, you name it. So they were impacted harder. And then I think, the onslaught of mass vaccination, without appropriate research, and of course with this distrust and lack of healthcare literacy, would ultimately have resulted in the sterilization of Black and Brown people. Black and brown impoverished people at that. Because the big trillionaire researcher, he killed the doctor and said, hey, we're not going to stop production. We got this vaccine, especially for the poor Black people who are suffering the hardest. I think this has been manifested. We're seeing this now, how a virus, or bad clinical decision making, in concert, not only between scientists but in governance, can impact the poorest of the poor and the most disenfranchised. And it's something we got to do about it.
So I'm struck by how this pandemic has really underscored all of the injustice that exists in our country, that's existed throughout the beginning of our country. So Bryan, you reference it, right? That the health disparities and social determinants of health, all a result of a broken system that put people in positions, did not give people opportunities, segregated people because of racist beliefs. And so we've set ourselves up for this moment. And at the same time, concurrent with all of those racist policies, where the medical profession is doing research on those same populations, the populations that aren't seen as human. So Black and brown bodies, institutionalized individuals, very poor white people, prisoners, Jewish people, Italians. I mean, it's it's immigrants, right? It's the others. And we're going to do our research on these populations because they're not the populations of power. And the findings of the research is going to benefit the other. And so we come to this moment where it's justifiable that somebody who comes from a population that has been historically treated in this fashion is not going to trust the medical profession. And now when we're finally saying, but wait, we hear you now, and we understand, and we not only understand that this pandemic is having a disproportionate effect because of our prior policies, and we want to do right by that. So what we'll do right by that is we'll make our vaccine that is brand spanking new available to you first. And we want it to protect. I mean, we want it to be seen as a good thing. And now you have a problem, because how is that different than what you've done in the past? And so, how many rich white people do you need to line up and say, I'll take it first, so that I give you comfort that it's really intended to be, to have the impact that we want it to have, which is to save the most Black and brown bodies that we have set up to be most harmed by this. It's a mess what we're in.
It is. And speaking to that point, that's why we saw so much advocacy, so much advertisement for people of color to participate in those COVID vaccine trials, because we weren't represented. I was introduced already, but I graduated from Xavier University of Louisiana, and the government was creating partnerships with HBCUs so that they could advocate for HBCU students to join these trials. And it's a double-edged sword. If we don't participate, then long term, when we get vaccinated, maybe we experience some unintended consequences that could have been figured out, in the clinical trials. But, the other side of the token is that, there's been, there's a complete lack of distrust. There have been so many lies, so much misinformation. How do we get to the point to where we trust the system again? Especially when, top healthcare officials and governments already, they don't trust, they don't see science in the same accord.
So here's where, before I just want to jump in real quick, Shani, to say, this is where I want to give a shout out to Dr. Linda Clark and Common Ground and the health and the work that our Black and brown physicians and healthcare providers, our PAs and our nurses are doing to get out to the community, into the communities that we serve, the message that we're trying to give, because those are individuals who the communities can trust. And that they need to be helpful in giving that message.
So I think, you know, and Margie, you and I had a really great talk about this earlier. So I'm going to say, you know, I think that, you know, I think that there is a lot of trust building that has to happen. We know this, right? And we talked about the lack of time. There's not enough time. You know, a recent poll, a Pew Research study talked about 72% of Americans across the board are would be willing to receive a vaccine now for COVID. And of those 72%, 54% of African Americans would receive the vaccine, which, you know, those numbers do not surprise me. I think I was surprised it was over 50%, honestly. You know, I think that, you know, one of the things I think that I think that the frustration is as people that are seeing people die, right, that we are seeing disproportionate COVID disproportionately affecting African Americans, you know, Latinx folks, that, you know, we want people to be safe, we want to save you, you know, but we have to understand that it's like we are already dealing with so much mistrust because it's been consistent mistrust, right? It's been like, if you're putting like all your change in one piggy bank and then you're like, well, I'm not going to put that change anymore in there, but then there's a giant piggy bank sitting there and you're like, don't look at it though, look it over here where it's empty. It's like, but they're like, but all my money's in there. You know, it's like we are insisting that people trust the system, even though the system doesn't necessarily want to change anything, but we want to save your life though. And that's what we're going to do. So we're going to do that real quick over here. And we want you to ignore all this over here. And I say the word ignore because the consistent message at the highest levels of healthcare is that we are here to, our message is that we're here to make money and that we will do so as long as and we'll take care of you, but we're here to make some money though. And, you know, my message to healthcare, you know, healthcare at the highest levels in Rochester is that, you know, you need to have a consistent message that is the same every day. And that is that there needs to be some, you know, real work done in the community by community members and not them telling community members what they need to do. Because really, you know, the whole thing about reaching out to folks is validation of their fear, right? And that you can sit right beside them and say, you know what, I don't have an answer for that. You know, I know that happened. Here's what we're doing though. And then move forward with that message by building community within community and not having people come to the healthcare centers in which they work in. So I know we've got like a couple more minutes. So before we take some questions. So one of the things I wanted to say is, you know, the future. And what do you think that healthcare systems can do to continue to foster trust within the Black and Brown communities? And I'm going to say here specifically in Rochester, since that's where we live.
So Rhonda, I'll start if that's all right. I'm going to acknowledge something that has happened as a result of the COVID pandemic that gives me hope for the future. And so the ethics committees at the RRH system and the U of R medicine system collaborated on questions of resource allocation because it was, we all collectively believed that it should not matter which hospital you attend, where you show up, to what resources that you can get. And so how do you navigate this? And as part of that process, I became, I was able to participate in conversations that UR Medicine's leadership had around these topics. And I was incredibly inspired by UR Medicine's leadership around making sure that all patients are served in our community and served fairly and justly. And hearing in the leadership calls, hearing that message not being broadcast for the purposes of the public hearing it, but being leadership for the purpose of leadership within the institution, and having those same leaders make decisions about including community members in our deliberations throughout the whole process, which is not typical in institutions, medical institutions or academic medical institutions across the country. We really, our leadership took a stand and said, that's the right thing to do. even if other people aren't doing it, this is what we need to be doing. And our leadership accepted and engaged community members in this process. And so that's the first thing. You've already said it. That's what we need to do. And what gives me hope is that our leadership is doing that now. I also think we must do something that we have done poorly and maybe starting to do better, is that we have to acknowledge our past, and we have to acknowledge the racist practices that still exist and the systemic practices that that perpetuate that, so that we can become the anti-racist organizations that we want to become. And I think we're starting to, and now I want to turn it over to Bryan and say, this is because we're starting to do this because of the work of organizations like White Coats for Black Lives. We're starting to do this good work.
Ooh, recognizing a history of racism, it lights me up, because I was baffled in September when the president released an executive order, and I'll never forget these words. And it was like intended to promote unity in the federal workplace and combat anti-American race and sex stereotyping and scapegoat. And it was in September, released an executive order. Now, I chatted with a friend over the holidays, and me and my friend are very critical of each other, like good friends are. And she said to me, she said, in 3,000 years, Bryan, will anyone remember you or anything you've done? Now, with this executive order, the president literally is seeking to rewrite history and gaslight institutional influence on Americans as a result of slavery, racism, sexism, you name it. Now, in the order, you got to read it because it's online, and read it with some wine because it's baffling. He goes as far as saying that the diversity training that happens on the federal level is communicating unconscious bias, especially, it's communicating that unconscious bias exists, especially in white people, and we can't have that. And I think that that's an issue. That's an issue when we deny our history, and we can't make progress if we can't accept it, be accountable for it, and work to address it. And I'm very honored to be a part of White Coats for Black Lives. It's a national organization, but the URMC's chapter includes a hodgepodge of students, trainees, physicians, PAs, nurses, medical professionals, faculty, staff, literally anyone who is involved in patient care, medical education, science, and wants to improve the experience of people of color. Our work isn't exactly like, but it intersects with a whole host of organizations who are doing really good work in the Rochester area. I'd be certainly remiss if I didn't shout out a few. The Black Physicians Network, the Student National Medical Association, the Alliance for Diversity in Science and Engineering, Spectrum, the Department of Public Safety Advisory Board, the Graduate Student Association. Free the People Rochester is another big one. And I'm probably leaving somebody out, but they won't mind, because nobody does this work, for the recognition or the money. And I mean, the money doesn't even exist. Nature published the article actually and described the time tax put on professionals of color. And that tax, via White Coats for Black Lives, began with an absurd amount of research into the infrastructure that is the University of Rochester. To articulate the issue of racism, we needed to understand it completely. And what we found was that URMC was failing at matriculated student representation and faculty recruitment. Items exist on campus that celebrated racist individuals. Our medical education curriculum didn't explicitly address racism in medicine, and instead used comfortable words like diversity and microaggression. And we didn't name racism as even a factor for influencing health disparities. Students additionally on campus reported things like police force and disparities in grading, issues with administration of honors, like the AOA, which is a big honor society. If you get an AOA, you can go to any residency you want. And there was no valid system for holding any of these groups accountable. And very recently, in the wake of the Black Lives Matter movement and the multiple unjust killings that have occurred, especially this year, which have been followed by, probably the biggest movements we've seen in contemporary times. The physician, Dr. Gilda Johnson, reminded us that she sent a letter to, every higher administrator at the University of Rochester. And she reminded us, the change makers of today, that this work to address racism at the U of R began even before most of us finished our undergraduate education. In that letter, she wrote that in 2014, 60 students in their white coats, arguably the pilot group for White Coats for Black Lives, held a die-in in the Office for Administration. And they protested the murders of Michael Brown and Eric Garner. And on the undergraduate campus, things, weren't, uniquely different. A year later, racial tensions were boiling. I don't know if you all remember the app Yik Yak. It festers racial tension, and multiple minority interest groups submitted a petition to the president to address, those intolerable acts of racism that were occurring on this social media app. But today, White Coats for Black Lives, we've facilitated protests, authored demands to address racism, and work with administrators to address inequity and racism on our campus and throughout classrooms and within our hospitals. The campaign is informally titled Actions Speak Louder, with a hashtag in front of it. That's what's trending now. And as a result of the efforts of White Coats for Black Lives and tons of advocacy by groups at the U of R and in the greater Rochester area, the U of R released the Equity and Anti-Racism Report. And it seeks to build an anti-racism infrastructure, as Dr. Shaw has already alluded to, through policy review and training, improving diversity through recruitment and partnerships and mentorship, and creating culturally sensitive spaces. And I'm not equipped to speak on that policy as a whole, but the year one milestones include a research gathering phase and a wealth of leadership training. And rest assured, White Coats for Black Lives will be holding them accountable all the way.
Come on, White Coats for Black Lives. Very excited. When I read your, before we start the questions, I was so encouraged to read your, the statement that was put out by them. I thought it was just amazing. And, being a Black clinician in this town, it was so refreshing to see. So you guys keep up the good work up there. We're very proud of you guys.
Thank you so much.
Yeah.
We appreciate the support of the faculty and staff and
right.
healthcare professionals alike that, keep us, moving forward and lobby for us at every level of administration. I am a fan of the Dr. Shaw soapbox.
Uh-oh. Yeah, I'm a fan of hers as well. Okay, so question number one is from our group here. Dr. Shaw, I wonder if you can answer this, or Margie, sorry, excuse me. How do these issues that we're speaking of today impact patients currently in the hospital for COVID-19?
So I'd like to say not at all, but I think that would not be fair, right? So because we haven't solved these problems, we still have individual biases. Most people, all of the people that I know in the institution make an effort to be anti-racist, but that doesn't mean everybody in the institution does that. And so we have to always pay attention to how we're treating everybody in our institution. Our institutional policy, and we've done a lot of work on this, is that we are an anti-racist policy, that we cannot and will not discriminate against any individuals because of the color of their skin, their immigration status, their gender, their sex. We aspire to be and uphold ourselves to those standards. And so the question, I'm struggling with answering the question because in theory, we treat all of our patients with love and care. But the individual experiences are ones that I can't answer to what those are. I mean, I don't want to, what I'm being careful about is that I don't want to not hear or undercut any criticisms about any individual actions that are happening at our institution. And Bryan listed a bunch of them, and those exist. I mean, it's real. And yet, what I can say is our institution is, and our individual providers are working hard to make sure that racism and discrimination is not a part of our culture. I think the question that you're asking is, also might be, are there things to make sure that we don't have decision-making policies that disproportionately impact underserved populations? And our policies don't do that. We have to acknowledge in this conversation, though, that medicine does that. Our science does that. It rests on racist understandings, and that we haven't done the work to unpack all of those racist understandings. And so I noticed an earlier question was asking about sort of allocation of resources. We don't allocate resources based on color of skin. All patients are treated equally and fairly in our institution. But if you come into our institution as somebody who's been underserved in our population, you're going to come in with poorer health measures than somebody who comes in with who has been overserved. And so when you come in with poor health measures, you're going to be sicker. So you'll get more resources because you're going to be sicker, but that's not what you're looking for. What you're looking for is better health, right? And the only way to really get better health is to fix the underserved problem that gave you poorer health when you walked in the door. And so we have this problem that medicine, in the hospital medicine and hospital healthcare, can't fix our racist structure. What we have to do is fix the racism that we're perpetuating within our own building and within our own practices. And that is work that we're doing. But we still have to acknowledge that we aren't fixing racism even when we provide anti-racist care.
Yeah, and I know from an earlier discussion that we had, we talked about systemic racism being folded into the system, right? And that there is going to have to be, it's like taking a thread out of a carpet, right? That, yeah. So, you know, I mean, I think the thing is too, is like one of the things that we wish to see as local folks, local clinicians, local people that live here, is that we want to see a sustained commitment to, you know, racist, systemic racism, institutional racism, implicit bias, explicit bias, whatever, that is actually on paper, that is actually being done every day, that is actually quantifiable, right? And I do want to go ahead and move. I do want to go ahead and move on though to the next question. So somebody's asking, how do you ethically balance the need to give patients time and informed consent through multiple sessions, like I mentioned, with the affordability inaffordability and barriers of access to healthcare due to poverty, race, conditions, disability, gender identity, and sexuality as a medical professional? So they pretty much named everything that we do every day in our clinic. You know, it's like, so, and the person who wrote this can clarify further if they need to, but basically you're just saying, like, how do you do all that when you don't have time to do what you need to do? So I would say, you know, again, you know, I don't know what type of medicine this person practices. I'm assuming that they do from their question. But, you know, one of the things I think, you know, we build relationships over time, and you know that it takes time to undo all the things that racism, you know, sexism, misogyny, homophobia has done to people that live here. And so we can't solve everything in a day for anyone. And so, but what we can do is, you know, I tell my patients, you know, how do we eat an elephant? We eat it one bite at a time. And, you know, I know that that may not be the perfect answer, but really, you know, we are dealing with imperfect answers for imperfect people. I'm imperfect. Clinicians are imperfect, you know, but I know that, you know, one of the things that matters to me as a Black woman and to other people that look like me is that I'm able to trust the provider that I'm working with to actually treat me fairly as a person, as a human. And, you know, that trust is not established in one meeting, right? You know, we talk about, you know, it'll take me months or years to get somebody to get a colonoscopy, but I will still try, because that is what, obviously, I'm trying to save that person's life, but also because I care about that person, right? So, right. And one last question here. How is implicit bias being dealt with by current clinicians and future clinicians? Is training mandated? And I wonder if you both can answer that. I know that you're that you're both, you know, within the system of Strong. So
it's probably a better question for Dr. Shaw.
Well, we have been increasing the work that we've done in training around implicit and explicit bias. And one of the things that I'm proud to be a part of was Dr. Adrian Morgan invited me in to this work about 4 or 5 years ago, where we started using theater methods to teach our clinicians how to respond to racist and inappropriate discriminatory comments. And so we do these in training sessions. We offer them to our residents. We offer them to our medical students. They're simulations, and these trainings have two parts to them. One is that how do you respond if you are the target of inappropriate comments or behaviors? And the other, and maybe even more important, is how do you become an ally to somebody who you witness be the target of one of those inappropriate comments or behaviors. So one of the things that we have in medicine that's been unfortunate, that's a part of medicine, is this silence of not standing up for your colleagues. And so we have this silence in lots of different ways, but to not stop inappropriate behavior, to not be an ally, not to say, I heard that and that was not acceptable. And we have policies that don't permit that. So teaching our clinicians how to use that language, we are integrating that in our training sessions all the time. Our programs, our residency programs, it is becoming part of the fabric of our education, which is nice. And Bryan's right. We did not do this 4 years ago. This is new work that we're doing. We started it, what I said, with Dr. Morgan about 4 or 5 years ago, but that's just a little bit. Now we're increasing it and adding it and doing much, much more of it. Bryan, you'd love to see the medical humanities and bioethics selectives that we're offering to first-year medical students this year. They're going to be on, there are many of them, about 10 or 11 that are on, have different topics, including epistemology and trust, racial justice and a pandemic, race in medicine. We're offering these now as part of the first year students class. So in addition to being in the hospital, we've moved it into the medical school, and this is all new.
Yeah, and there was a call to a question from the audience about a data-driven approach, to sort of dissect, where institutional healthcare decision-making is. And the example I provided about headache complaints to the ED and the response thereof by clinicians was a real one. And that was a study done at U of R. I think first, that the data-driven approach begins with researching the problem and figuring out exactly what's happening. And then the creation of some standardized approach, for how we meet a chief complaint with a therapeutic response. Dr. Shaw has alluded to it before, and it's a sticky subject. The law can be anti-racist, but the law is subjectively interpreted and actualized by other people. And I think that's, the harder part, to address. We know racism is deeply rooted, and the things we see in clinic, aren't the roots or the trunk or the branches. They're the leaves of the symptom that is racism. And I don't think we'll ever pull the tree out from the ground. What we want to address at some point, are all of the leaves, but eventually those leaves just grow back. And, at the policy level and at the professional development level, at the training level, and then I would say beyond that, at the consequence administering level, there's got to be consequences for racism and medical malpractice. That's where we begin to hit those branches and eventually working on that trunk. And I think that the changes in healthcare, the changes made by hospitals to address institutional racism have to be followed up by calls to action in other sectors in the world, or else they'll continue to exist.
So yeah, that was awesome. And I think the thing too is I love the fact you said about the roots of a tree, and recognizing that, the roots of racism and, these types of things have been perpetuated for generations here, specifically in Rochester, which is where we live, right? And I think that, we talk about the next generation, we talk about policy and procedure, and a group of young people that are like White Coats or Black Lives that are, speaking up, demanding, shaking the table, shaking the tree, as it will, to make sure that, these things are addressed. This is a new day. We are demanding from these at the highest levels of healthcare within Rochester that things start to change. And we will continue to do so because we know that they need to change. And, data-driven approach, experiential approach, like, clinicians like us and people that work in healthcare are important. And, these conversations are important and they need to happen. And so, we are thank you so much for joining us, everyone. I know we didn't get to address everything, but as you can say, it's a snowball effect, right? And it will keep getting bigger and bigger because this is a topic that is just something that we're all very passionate about. So thank you so much, Karan.
Yeah, I just want to just jump on here really quick to thank our panelists, Margie, Bryan, and Shani, and to all of you who joined us on a Tuesday evening. Very appreciative. Please go to recognition-radio.com if you haven't yet taken a listen to the Bleeding class. And we are also releasing our next play, The Resurrection of Michelle Morgan, a week from today. So all 4 plays will be available starting next Tuesday. And if you look at the community page on the Recognition Radio website, you will see our upcoming events, including another community conversation this coming Thursday, our 3rd in the series, at 7 p.m., and a 2-parter next week, Thursday, December 10th and Friday, December 11th, which Shani will also be a part of. So lots coming up. Please stay up to date. Check out the Recognition Radio website. And once again, thank you to Margie, Shani, and Bryan for a stimulating and really important conversation. Everyone have a good night. Thank you. Stay safe. Wash your hands. Wear your mask. Thank you.